Hi, good afternoon. I think we should try to start again. We are going, as said, we heard already Dr. Marwan to talk a little bit, but I invited him and one of our, she's a patient, an ET patient, and to explain a little bit, he will first explain what with his hospital, which is probably one of the biggest one, how it works, and then we will talk a little bit, how a patient in Saudi Arabia is living, and when he gets diagnosed, how do you get to doctors, etc. Yeah, Dr. Marwan, if I can give you the word, you explain a little bit.
Thank you very much. I'm very happy that I met Peter in one of the meeting, in the MPN meeting, and it was in the lunch, and I told him I want to establish something in Saudi Arabia to explain, to do awareness in the patient, because this is really a gap in our area. So Saudi Arabia, I work in one of the big hospital. Actually, I think it's the biggest hospital in the Middle East. I have slides for that. Sorry.
No se me ve a mí. Qué bien.
Oh yeah, this one. So this is our hospital. So it was established in 1977. The reason they want the Saudi patient not to travel to abroad for the oncology or cancer diseases. So they established this big hospital, and it was run by the United States of America mainly. All the doctors were from there, all the nurses, and slowly transformed to a multinational. We have 17,000 employees, and from 70 countries in the world. And it's a big, with the, I cannot change the slide. No. Here? Oh. Okay. Maybe we'll just skip the slide. So we established allogenic stem cell transplant in 1984. So it's like 35 years of allogenic stem cell transplant. We were the first in the country to do that. Yeah, this is the initial phase in the hospital. Maybe you can change. Next. So I prepare a few slides about what's the program and what we do usually. So we have also prize, like they label us as one of the top hospital, and we have the chimeric antigen, which is CAR-T. This is the new technique on treating cancer, mainly lymphoma. We established that. We did 100 cases. And in the last 3 years, we have a special section inside hematology for chronic leukemia and MPN. So all the MPN patients come to our section. In Saudi, our age population, or the average age in our patients or in population, is 33. So we have younger population than usual, and that's why all the disease, actually, not only MPN, all the disease, they present earlier in the case. So we have like CML sometimes in pediatric, we have myelofibrosis in 20s, and like Wad, my patient, she was diagnosed with ET at the age of 15 years. So this is unique maybe in our area, also in the Gulf, in the GCC or Gulf countries. So and also Saudi Arabia is a big country, so we have referral from outside our center. So this also, we have a challenge about late referral. So patients will be seen by the local doctors, and then when they diagnose, they will refer to a big center. Sometimes the big center in the city will keep the patient, which also important to do awareness that this is not good, because they need really to seek a specialist in the field of myelofibrosis or the hematology. But we are doing fine in the easy acceptance and referral. The government will pay all our health care is free for the citizen, and also
Recording in progress.
They pay also for the ticket. So from that aspect, we are fine. We have also all the new medication, which is very good. We have access to the new medications. We have so my slides, if you go, there is also about the research in my center. So we have, just move, move. We are one of the top 250. This is the transplant, how we from start, how increase the transplant number. Now we do around 400 allogenic stem cell transplant between adult and pediatric, and 400 in one center. This is very huge, because we are number 5 of North America. We come, so number 1 in the world to do, in the North America to do allogenic stem cell transplant is City of Hope. After that, Mayo Clinic combined, there is 3 branches. After that, there is maybe Seattle. Seattle is one of the big as well, but maybe New York, and then King Faisal in Riyadh, so as number-wise. If we exclude, of course, China, I heard also in China they have a huge number in one center. So I'm talking in one center. Next, please. This is the CAR-T that I mentioned. You can go, this is the CAR-T. This is the first patient of CAR-T. This is a celebration of 100 CAR-T. Next. This is now our number. So this is just, I told about how many transplants we are doing. The clinical trial is something really, we are proud because it's increasing, and it's, maybe you go to the next one. This is our own manufacturing CAR-T. So the cost of this CAR-T is around 400,000 euro per patient. 400,000 euro. So good that we have now the manufacturing we are doing, and this reduced the cost to only 50,000 euro. Next. This is what I mentioned about number 5. So they give us like that you are from the CIPMTR. This is the transplant, the North American Transplant Foundation. They say that we are also from the top 5% as a number, and quality as well. Next. So the clinical research. So that, next. So the trial, we are doing more than 380 clinical trial in the year, and out of this, 25% is hematology, which is really good. So hematology is very active in clinical trial. So this is just to tell you about all the activity in our hospital. So if I can ask you, how many BV, polycythemia patient, can raise hand, please? Okay, and how many ET? ET, slightly more. And myelofibrosis? Only few myelofibrosis, Oh yeah, so only 5, 6 myelofibrosis. Nice. So I think now I will,
Go a local doctor, no? Yeah. And once he comes from a local doctor, he will send to a specialist.
Yeah, so they will put it in a referral system, and usually there is a cluster. For example, Riyadh patient will be under this cluster. For another city in the north, they will go to a different cluster. But we build like awareness about us, about our section, and they are sometimes directly sending to us, which is also good. Because of the travel, so usually I like to have the patient who is geographically near Riyadh, and if they need transplant, they will come, because myelofibrosis transplant is very difficult. If they present late, I mean, if the patient presents late, already receiving a lot of blood transfusion, each unit of blood will contain 250 iron. So this iron will store in the liver. Usually the liver is the storage of the iron, but the normal situation there is only 1 or 2 gram iron in the liver. But if you take blood transfusion, like in thalassemia, for example, or myelofibrosis, when they reach the stage that a lot of blood is required, so this iron will affect the liver, will affect also the graft, the new cells, the stem cell. So this make what we call graft failure, like the new cells can fail if there is a lot of iron deposition. So sometimes we have to give iron chelating agents to make ferritin, which is the marker of the iron, to make the ferritin less than 1,000 or 2,000. But sometimes it's too late, patient receive a lot of blood transfusion. And this is very important in awareness that we need to talk to the doctors from the local hospital. Don't keep the patient if they are young. Usually in our center, the myelofibrosis transplant, we prefer 65 and younger. But in the US now, they are doing up to 75 years, 79 years transplant. But you know, it's bad when the patient is around 65 and they keep giving only transfusion and they not refer to a transplant center. You need to go to a transplant center, identify the donor early. At least we will search for a donor. Even if you not need a transplant now, we can just observe you, but please, I keep telling, refer to a transplant center.
How many transplants are you making
So
per year?
Yeah, so in only myelofibrosis, we do maybe 10 per year only, out of the 200 in my center and in pediatric another 200. But usually for myelofibrosis, to reach the transplant need preparation. As I mentioned about the problem, number 1 is the iron issue. Number 2, the spleen. If the spleen is huge, hard, the new cells will face, the stem cell will face the problem that will go to spleen and they will not have the engraftment. So we need first to prepare the patient by giving those JAK inhibitors to shrink the spleen, reduce the inflammation, and make the condition of the patient better for transplant. And I don't know if you want quickly to mention about the transplant procedure. So usually we will, as I mentioned, prepare the patient, and then also we will give the donor injections for 5 days to produce the stem cell from the donor. And majority of the time, the donor only will give the stem cell from the arm, like donating a platelet or blood. It will take 2 hours on the machine, and we will collect the stem cell. Usually we need 5 million of that stem cell, and we will try to do like the roadmap to have those cells same day of we call it day 0. Before that, before day 0 for the patient, we will give chemotherapy. Usually we give 3 to 4 days chemotherapy for the myelofibrosis patient in order to prepare the immune system and prepare the marrow to receive the new cells. And on day 0, we will give the cell, and then we will observe the patient in the hospital. So usually the transplant patient need to be admitted at least 3 weeks, full admission. Out of those, there will be a period that your immune system will be down, the blood will go down, so you will need blood transfusion and close observation till the new stem cell, the mother of the cells, will go and produce platelet, blood, red blood cells and white blood cells. And this usually take 2 to 3 weeks. And after that, if the patient tolerated the immunosuppression, so we have to give immunosuppression in order the immune system not to fight the new cells. So we have to make the immune system on sleep, little bit sleep, and we will wake it slowly by decreasing the dose slowly and they have to be in the same city of the transplant center because they have to visit us 2 to 3 times per week, minimum 2 times per week, because we have to measure that immunosuppression level and we have to check for the complication. So number one complication that we always afraid is graft versus host disease. The immune system attack the body, and this is the major complication of the transplant, and also infection. Infection is very dangerous because we are giving immune suppression, so the immune system is down, so easily patient can develop infection, and this infection, so we say when you have a fever of 38, you have to come within 1 hour to emergency room, because we need really quickly to do blood culture and to give IV antibiotic and to admit the patient. Usually we call it febrile neutropenia, like low neutrophil with the fever. It's very dangerous. If I talk also, I don't know if I have time. So if I talk about how we manage the patient, so usually, as I mentioned, there will be young ET, young BV, and I feel bad because good percentage of my patient presented of liver failure, liver cirrhosis. So they will have the JAK2, let's say 10 years before presentation, and the JAK2, BV or ET will cause the thrombosis in that portal vein, which is draining from the liver and the spleen. And when this clot happen, the patient will have abdominal pain. They will go to emergency room, and no one will think of that because it's rare. No one will think that this is a problem of JAK2 or so slowly there will be collateral and there will be portal hypertension. This means that the liver will get because there's no drainage, so the liver will be harmed. Help me with the English words, please.
I'll try my best.
Yeah,
no, you're going.
With
You're
the
going.
English words.
Really well.
So usually the liver will be very upset and angry
Yeah.
because they will not drain, and then because of this pressure, the spleen will be large to relieve little of this pressure, and also the esophageal varices, which is the varices is like the pockets of blood that comes from the esophagus, and this is dangerous because sometimes it will bleed. I have a patient who presented not with liver symptoms or liver failure. So what is the symptoms of liver failure? How you will know that your liver failed? You will have jaundice, and you will have sometimes itchiness, and sometimes it affects alter the consciousness, and ascites, fluid in the body, in the outside in the abdomen. So one patient presented with the GI blood, like what happened with alcoholic patient. Sometimes they bled, and she was young, and she presented this way. And the worst thing also, if they go to the liver doctor who is not aware of JAK2 as a cause, and they are not doing a good workup, and because the liver, when failed, you have to quickly act and do sometimes liver transplant. Liver transplant in my center, we are doing more than 200 or 300 huge liver transplant center, and majority is living related. Our family support in Saudi is very good usually, and really when a member or a brother need, even the cousins or they give. So the good thing about liver transplant that you can donate part of the liver. Usually they take 2/3 of the liver, big amount, but the liver within 6 months will grow. And I don't know, maybe it's not our topic, but maybe good to know as a general information how they will choose the donor in the liver and kidney. Only you need to have the same blood group only, and the donor must be thin, with no diabetes, no other complication, no other disease that can later affect the liver. But the success rate is very good, and they are doing now robotic liver surgery, and it's good. So back to our those Bat Chiari, we call it portal vein thrombosis Bat Chiari. If the liver doctor didn't know that, what will happen to the new liver? So they will put a new liver And then again, can another thrombosis affect the new liver, and they can lose the new liver, which is really bad. And that's why now they are always do screen of JAK2. The JAK2 lab can detect only if it's more than 2%. So in some lab they will not detect. So, but in polycythemia, JAK2, how many percent of polycythemia or have JAK2? Anyone know?
661, sir.
No, I mean the percentage of polycythemia. It's 98%. So majority, all polycythemia will have JAK2. All polycythemia will have JAK2. But in 80 for platelet, no, it's maybe 50, 40, 50 only. We have one.
Special.
So maybe we'll leave that. Yeah. Waad, tell us about your story, please. And we'll get questions later.
Hello, everyone.
Oh, there we are.
Okay. Thank you for having me here. It's a great opportunity to learn more. Thank you, Peter. My name is Waad. I'm 33 years old from Saudi. When I was 15, I started to have a really bad headache, like migraine. I felt like heavy in my head, and I was so sensitive to the light. So I've been taking painkiller every day. I spent 2 years looking for the answer until one doctor asked me to do the full blood test. That the results showed that my platelets was so high, around 1.5 million.
1.5 million, yeah.
Yes, 1.5 million.
But can I stop you? So before that, Waad, you were like going to which doctor? Which kind of doctor you were going?
It's general doctor. Yeah.
So, okay.
Yes.
And when they ask you about the headache, they will investigate for sinus. You know, she was going for ENT mainly doctors sometimes,
Yes.
and no one think of that ET. No one.
Yeah.
So 2 years she was suffering, visiting here. Even her parents think that she's like seeking attention.
Yeah. Yeah, right.
And in the school, you were not doing well in the school, isn't it?
No. I had to stop it. Yeah. Sometimes. Yeah.
So many absence of the school because of not feel well, headache, lightheaded, and also maybe the numbness, the tingling, the needle sensation, all this. And finally, one doctor say, "Okay, let's do CBC," and he found the platelet 1.5 million.
Yes, they were. He was looking for anemia. Yeah, maybe.
The reason
maybe
why he
the reason. Yeah. So he sent me to a hematologist who did the bone marrow biopsy. That's when I diagnosed with the JAK2 mutation, essential thrombocytosis. Since then, I was taking hydroxyurea and aspirin daily, and I felt so much better. Almost the effect, the headache almost gone. So when I was 26, I get pregnant. So I start a Pegasus injection weekly and aspirin. And around 6 weeks of pregnancy, I had a painful and heavy bleeding. It lasted 2 days. So after that, eventually the doctor had to induce abortion
because of the heavy bleeding.
Yes.
So it was like heavy bleeding, and they say no, this is we must interfere. So only it was 6 weeks of pregnancy.
Yes.
And platelet were like...
We're 700.
Yeah, we're like 700 with the Pegasus. So usually with the pregnancy, platelet will go down. This is normal. each pregnancy, like some pregnant ladies will even have the platelet lower, even like 600, 500. So why we give WAD bigases in order to make the marrow and to avoid the effect of the thrombosis of JAK2, try to calm down the things. And also we add aspirin, of course, to prevent thrombosis, because abortion will be like a thrombosis event. But unfortunately with her in the 6 weeks, the bleeding was massive. She was admitted and the abortion was done. So how the abortion is bad experience,
Yes,
isn't it?
yes. It's so painful. It's emotional. It's so hard to me. It was difficult experience that make me so worried, so scared to get pregnant again. But my doctor here, Marwan, recommended to add enoxaparin to my next pregnancy from the beginning. I was on enoxaparin daily with bigases and aspirin. So
I remember enoxaparin was painful.
Yes, it
She
was
said,
very
Doctor, it's
painful.
very painful, burning.
Yes.
It's burning like the injection, the blood thinner, enoxaparin.
Yes.
She was taking in the thigh. I remember I advised her to put some ice. Sometimes putting some ice will make the area numb, and then you can have the injection. But 9 months of daily injection, 9 months.
Yes.
And you were very worried during the 9 months.
Yeah, of course, yeah.
Because she did, one time there was an abortion with her bleeding, so the whole 9 months she was really worried.
Yes, but with this treatment plan, I was able to carry the pregnancy safe. And now I have a healthy baby boy. He's 6 years now. So, so this to being a mother, it's most beautiful and emotional things that happened to me. It's really worth all the pain, all the needles, all that. That's it. Yeah.
This is very important.
Yeah. Thank you.
It is very important because sometimes when the patient started on hydroxyurea, the doctor will say, avoid pregnancy, avoid.
Yes.
And this is really, some of the patients will reach like 40 and they are afraid from getting pregnant. And this is, I think, our job to, even for liver transplant now, our liver transplant team told the younger patient to no pregnancy, which is unfair. I keep telling them, no, you should fight to have the children if you want. So the pregnancy, MPN and pregnancy is not well, there is no enough data. It's a gap in our practice. So there is no clear guideline. Some of the doctors think that bigases is harming the pregnancy. So even they say no. And I was in the CML meeting recently, and there was data from Russia. They review the pregnant lady who received for CML, different disease, CML, chronic myeloid leukemia. But they review the data and they say between patients who achieve pregnancy and achieve healthy baby, success pregnancy, they review that whoever took bigases and no bigases, and there was the same. So till now, I'm not sure if WAD was helped by the bigases, because initially the bigases didn't do anything. So maybe the enoxaparin with aspirin combination is very important. Sometimes one of my colleagues in Jeddah, he gave the patient twice daily enoxaparin. So for example, if WAD second pregnancy also was not successful, the next step will be to give 2 times enoxaparin against the evidence.
So,
there's no evidence.
If I interfere,
Yes,
thank you so much. Really lovely to see your son around.
Thank you.
But I was just going to mention that actually in the UK, the practice is to give PEG interferon. In most of the patients, if the patients are ET or PEB with a high risk, like a straight on to go for the pregnancy. So if you will present with a high platelet, we'll give interferon to start with, precisely to try to minimize, the risk of an abortion or a bleeding or any other complications. And in some cases, I agree with you, we increase the aspirin, but it's kind of that balance to not increase the risk of a bleeding, obviously. And the other thing we do is give the low molecular heparin, sorry for that, and also we including the 6 weeks after the delivery of the baby to reduce the risk of thrombosis. It's really important to, prevent all of these complications going forward.
Physiologically, the lady will also be like pregnant after 6 weeks. So until 6 weeks. So this is important because they have thrombosis risk.
And we are really lucky because in our center we try to just have these combined clinics when we have a special hematology and an obstetric. And I always say to my patients, you're going to be the VIP for the pregnancy, because you're going to have scans constantly, like every 4 weeks you see a hematology. Like it's quite intense, but the success at the moment, I think they're higher, like 75% easy to normal deliveries.
What was, I think, in the clinic, high-risk pregnancy.
Yes. Exactly.
She was seen every 2 weeks.
Yes,
of
he
the
got
pregnancy.
VIP.
That's right.
VIP.
Yeah.
What about with Rainy? Is it not better when
Well, we've been using during the pregnancy, obviously, with this whole complication we have over the last year, and same good success, to be honest. I know there is some teams that are going to start collecting more information because, again, there is not much studies in pregnancy patients in general, so this is a good opportunity for us to look in on those patients. Because, why will not our patients have family, isn't it? Why will it stop you? If you want, you can, isn't it? So it's just helping them, I guess.
One of my patients, she was 32 years with myelofibrosis. She was having one abortion. She's JAK2, myelofibrosis. So first one was abortion. And then she was not diagnosed with myelofibrosis. So the pregnancy, when the delivery happened, they found that her abdomen is full. So they did ultrasound, and they found the spleen is huge, like another baby inside. So they say, okay, why you will have the spleen? And then they refer to hematology, and they diagnose her with myelofibrosis. I started her on ruxolitinib. And she was that time 33 years only, and she keep asking, doctor, when I can have another child? I said, not now, please, not now, because you are in ruxolitinib, and it's contraindication. And Roxo, the JAK2 inhibitor, have what we call rebound effect. If you stop it, they will be like inflammation will go, and spleen will become again large quickly. Sometimes 2 weeks only stopping the Roxo, you will have the symptoms. So years gone, and then at the age of 35, she come to me and says, doctor, I am pregnant in Roxo. I was, what? What to do? I don't know what to do. So I was very anxious, and I don't know really. I told her, really, now we must stop the Roxo. But I don't know to give you biggest will help or no. In myelofibrosis, different than ET. So what happened that she developed abortion, spontaneous abortion, but I don't know really what to do with the similar situation, and also with her how to. She's having one boy, and she wants another child, and still I cannot help her.
I will go for PEG.
The problem, yeah. Any suggestion?
I will go for PEG interferon.
Stop and keep her when she's stable. Yeah. But the problem that she need a high dose of Roxo, so I'm not sure how this will happen.
Yeah.
But she's now 35, 36. We should help. Yeah.
But still, I have a few patients going with IVF from the 43, still considered quite young for that age, and they have beautiful babies. I saw the baby a couple of weeks ago. So. I do have another question for you, if you'd mind. I just want to know, because obviously you were diagnosed really young, right, for the standard age of MPN. How did you manage? Did you have any support? Because obviously my practice in the UK is different, so just wondering, how was that?
Actually, in the beginning, before I diagnosed, my family, as Dr. Marwan said, they feel like I want to escape school. I don't want to go. Yes, I don't want. Yes, I have even I don't go anywhere. I just want to stay home.
Yeah.
So when my headache came back, I can to take a painkiller and stay at my room.
Yeah.
After I diagnosed, they felt bad, so they didn't believe me. So no, I get the support from them after that. Yeah, very, and from my husband too. After that, yes, that's it.
I think sometimes, well, what I have from my patients, and obviously we have great patients here and there, is the difficulty to other people to see this, right? Because I guess no one can see that your platelets are high and you're having a headaches. And if you're having regular headaches, you're like, well,
what's wrong?
What's wrong?
That's all on your head. Just maybe your eyes, maybe from the TV, your phone. Yeah, yes, they.
Migraine. A lot of patients is migraine, and they are taking the migraine medication for years and years.
Yeah.
Undiagnosed.
And it's really the history, you know, that pathway to different doctors until someone finally does a blood test and see the high platelets and linking like, oh, actually it's something. It's a really common pathway, isn't it, for most of our patients, that no one can give me an answer, I'm having fatigue. Yeah, well, daily life, isn't it? Everyone has fatigue, but
and maybe the very high platelet help her, because, you know, other patient, when they have like platelet 600, they will say, okay, no, this is from iron deficiency. Because iron deficiency caused reactive thrombocytopenia, thrombocytosis, sorry, high platelet when you have iron deficiency. And many of the patients missed. So I forgot to mention something. We have what we called familial essential thrombocythemia. This is, I don't know, not common, I think, here. But in our area it's common. There is a mutation called MPL, but MPL have familial and non-familial. MPL P106 is very favorable mutation, and usually the platelet will go only 600-700, and the symptoms is less from this high platelet. There is no headache in many of my patients. Many of them asymptomatic, no symptoms. And this is good when we have, but we keep also observing them. Majority, when we do the next generation sequence lab, the NGS, to detect this mutation, the majority will have 99 or more than 90% of that mutation. What means that both parents have carrier, for example, or one diseased, maybe or two carrier. So that's why it runs in the family. So if they have, like, for example, 4 kids, you can find in 1 or 2 this mutation and this disease. And it's the progression. We reviewed 2,000 cases in the literature, and we didn't see any myelofibrosis in those patients. So we reassure them. They keep coming. I have cancer. I said, no, it's only a mutation. And this particular mutation, the risk of having cancer or leukemia, I mean, is very minimal.
It's called MPL 106.
MPL, and then the subtype, MPL, and then the subtypes is 106. And usually it's in some region, maybe in the Arab country, Middle East or Gulf even.
Yeah.
It's common in Qatar and Emirates and Saudi Arabia. And the problem, we misdiagnose those patients because Usually we do only the one MPL in our panel before the other MPL, and they keep saying negative. No, and later when we figure this, we add the full panel and we have diagnosis.
It's getting a little more complicated on the, as a professor saw before, this beautiful picture of the different areas of the P53, etc. But it's getting even more complex now because we have even other JAK2 mutations that are not related yet, or we don't know yet the significance. And if we're thinking about, sorry, I know John have a question. 1 second, John. But the JAK2 mutation B617F was discovered in 2005. That is yesterday in the medicine. Maybe some people in this room, it was like babies at that time. And we are looking now beyond that with the technology that we have to, this is what we call the next generation panels or myelogen panels, depending on the technology, the names that you use. But basically you're detecting even other mutations that maybe have a relation. I have a case of a patient that is, the JAK2 mutation is on the exon 22. So we have exon 14, exon 12, exon 22 now. And even the lab people didn't know the meaning of that. And I was like, okay, well, a new thing that we need to learn more because this is what we're getting in now, more and more. Sorry, I think John has a question there.
Well,
sorry.
I'm sorry, I have 3 questions.
Of course, go for it.
But they're not too difficult. The first question is, do you have a patient advocacy group in your country, and is it not active at all?
This is very bad, yeah. We not have. So in sickle cell, they have. In hemophilia, they have. Other, of course, non-hematology, I think they have, but they only start to have the rheumatoid, arthritis, those groups, only in the last 10 years. But in hematology, even for leukemia, for lymphoma, we not have. I remember when we did one awareness about a patient gathering, and they say, doctor, when I was diagnosed, even I search the social media, and there is no one from my country and Arabic speaker that tell about his experience. So please, for you as a patient, try to help, try to do more awareness, try to have this social media, and Peter really doing a marvelous job in this society. It's a need in all our area.
Yeah, of course.
Sorry, John. But the main reason of him being here is to find out what are the possibilities we can help him in order that he has a patient organization. Yeah. When I met him first time in Spain, actually, he explained me already of that problem. And since when we are working, we're trying to find ways. It's not easy because the structure of his country is totally different. It's the whole political situation, king situation. But I think we will be able to do it. We will come later on today or tomorrow when we talk with the hospitals. I think, we will be able to find solutions because it is necessary, absolutely necessary. But such a large country like, not only Saudi Arabia, but all your area there, but you must have a patient advocacy groups. Absolutely. In MPN, I'm talking.
So the Saudi FDA are afraid from any contact with patient from the drug company sponsor. They not want, and they are really having this rule very strict for the drug company. And the drug company initiated some awareness, but it have to be no patient. And also in the social media, they cannot put anything. And my hospital, when I talk to them, what about asking the patient to come, they say, okay, but also don't involve any company. Just do video for patient experience, and hopefully Waad will do, or our patient we will start to do this in the videos about the experience and put it in our website. But for a group like this, a very good group, this is, I think, a challenge about that you need, because it's a charity and money will come, and they're afraid from money source, who will collect the money. You have to have a legal organization. We have to observe everything where you spend the money. So as I think many other countries, but it will happen one day.
I think that many countries have now very active, independent PAGs that you can learn from, and I'm sure that anybody here is willing and able to give guidance how to do that.
Perfect.
So yeah,
Thank you.
I hope that you go home with some ideas how to take that challenge. The second question is more or less related, and that is, it seems that there's a lot of underdiagnosis in your country.
Yes.
And is there any kind of program or idea that you have to solve that problem?
So there's a big problem about this, and the solution is to make awareness not only for hematologists, because hematologists will know, but the other, like maybe ER doctors, ENT doctor, and they will not be interested to come and here they have a lot of ENT. For example, if I am an ENT doctor, I have a lot of meetings to attend related to my specialty. So how to do this? Usually hospital-wide, what you call grand round, and this is usually need more effort to do it, and many other diseases. So we have like a fatal diseases that no awareness, like TTB, thrombocytopenic purpura. We have the PNH, paroxysmal nocturnal hemoglobinuria. In PNH also they will come with urine like cola color urine, and the patient, no one will know. It's a very rare disease, and it can also damage liver, and unfortunately many of the patients diagnosed. So the drug companies, because there is a medication which is very expensive medication, so they did a good awareness in Saudi Arabia, and now really the diagnosis rate goes very high in this matter. Even they did like vouchers for test-free voucher. You go to this lab and you do. And initially Novartis did this with JAK2. So for if a doctor wants to diagnose JAK2 and no access in one of the small city or so, there's a vouchers. I think this is also a good idea. So awareness, number one, educating doctors. Number two, access to the test and make it. The liver now, they are more aware after the problem happened to many patients, but now it's better.
But if I tell you something, John, we are doing as well a lot of education in the UK. You will imagine that, well, everyone knows about PV. Oh, no, and the patients you present with the thrombotic events, I teach my registrars, my junior doctors, that is what you're going to see in your E&E. This patient coming with a thrombotic event, walking in the room, and you need to do a JAK2, because that's the way most of the patients will, well, not most, but it's a high risk. So it's all about education for doctors as well, and more for us to make the diagnosis, isn't it?
Well, I totally agree. I mean, there are too many people that come into the hospital already with an event, and they're all too late.
Missing.
Yeah. The final question is about Hydrea. I noticed that I forgot your name. Sorry, but your patient was started on Hydrea. In most countries, it's very unusual to give Hydrea to such young patients because of the probable long-term effects. Was this an exception, or is this still in the guidelines?
I usually not strictly follow the guidelines. So the guideline just to guide you, but sometimes when you have like WAD patient with very high platelets and suffering for like 2 years, I need really to help the disease, to calm the disease. I agree with you that usually the biggest will be the first choice for young because of this toxicity, especially in male. We notice that it affects the sperm and damage the sperm. So in the study, it's only 6%, 7%, but I saw a lot. And many of my male patients, after only 2-3 years of hydroxyurea, the sperm count become like 0. So now I'm avoiding the hydroxyurea in such a patient and try to use the interferon. So the problem with the biggest is Roche, the company sell it, and then no one is producing to our area. And there is this, the raw big interferon, very expensive. It costs €2,000 per month, so one box. AOB is here. Sorry, AOB, the company. So, but soon, biggest will come back pharma end. The new company is pharma end, but you know, the American market is very huge. So they first, I think, need to cover, and later they will come to us. Do you have any update, Doctor?
We have.
6 months in about the States,
Yeah. Yeah, we'll have it now back. Yeah, we have this conversation.
So the cost supposed to be like 600 euro per month, and biggest is before. I'm not sure the new cost, but it will be better than 2,000 euro. Although the raw big is more tolerable, and it's every 2 weeks, not every week like the biggest is.
Thank you for your explanation. I'm always happy to listen to somebody who's saying, I'm aware of the guidelines, but sometimes there's a reason to deviate.
So I was talking to Peter last night about this, that I love Dr. Hans Hasselbach from Denmark. He have the mission. His mission is to say what they are mentioning about the guideline is wrong in those situations. Don't leave those patients with JAK2. Don't leave JAK2 progressing the disease. And his fight that this can cause for them not only thrombosis, cardiovascular complication, portal hypertension, a lot of issues in the future. And his message is early. And he said with biggest and with interferon, some of his patients, bone marrow or the marrow is back to normal, completely normal bone marrow. So why not to do that? I mean, we should really do awareness about this more.
Okay, I would like to keep the break which we have programmed. Thank you very much for your talk. I just want, about the cooperation with Saudi Arabia and these areas where we will not be able to do that without the pharmaceutical industry. So, as some of them we are here represented, we really have to help people in Saudi Arabia, but they have patient groups. But due to the structure of Saudi Arabia and these countries, we need the help of the pharma companies. It has to be a combined effort between the patients and the pharma companies. So I will approach you on that when we have situation a bit more clear. Dr. Marwan, he will help us on that, and with what we have, we can very strongly force something in these countries, but without the cooperation of a pharma company, this will not be possible.